only have these other two located in the other phalanges, proximal and distal, or PIP or the DIP. Okay, how many phalanges are in the great toe? Two, right? You guys sure?
Oh.
Yeah, you guys are correct. And then last but not least, which cuneiform is the largest?
Medium.
Medium, we can agree on that? That is correct as well. Alright, 100%. Congratulations, guys. Stop. And what kind of projection is this?
Lateral knee.
Lateral knee?
Left.
That's the same image we just
Left
looked at.
lateral,
by the way.
yeah.
See? It's the same images on your worksheet.
So we already reviewed this, so I'm just skip
Yeah,
over
you
it.
can go through these. These are the same ones on the worksheet.
Medial.
But you can, let them name them.
Oh, okay. Well, my apologies.
Okay.
So,
Oh,
Medial.
that's the right medial oblique knee. AP.
Because the patella is
Towards the.
right medial oblique knee, and how can we tell it's a medial oblique?
The two.
Fib lateralized, exactly. The
The
fib
patella is
lateralized.
towards
The
the
fib is always located on the lateral side. And as you can see, the patella is shifting towards the medial. So that's how you know it's a medial oblique of the knee. And then the marker, right side.
That's why it's.
And then
Scary toes.
That's a,
Lateral first bit.
that's a oblique.
That's a lateral first digit.
Oh, lateral.
How does the position look on that one?
We're gonna go over it.
How's it look? You gotta turn the foot like so, and you gotta separate the toe. Which did you guys do that in lab?
Yeah.
Look like
Do
the
you need something?
tourniquet.
Miss Clayton? Did you need something? Oh, okay. Did you guys get to experience positioning the toes?
It's in my car.
It's tough, right? Those toes aren't very maneuverable like the fingers, right?
No, sure enough.
So you gotta have someone like either hold it in place, put like a piece of gauze in there. Sometimes they use like a tongue depressor to pull it out of the way. There's multiple methods. Gloves, you can use tape. I mean,
Tourniquet. That's
Wow.
what I
whatever you gotta do
remember.
to get those toes out of the way and out of superposition, you gotta get very creative with it, as you can
Gloves?
imagine.
Use the glove to pull like a tourniquet.
Yes.
Oh, okay.
Yes.
Okay.
We did it with a sheet, right, Cindy?
Yes.
Pull guys with a sheet.
Oh, no, that's the
A
Okay, so that-
sheet.
Yeah, so big.
Y'all got some big.
The way Mr. Fong did it. But then
So yeah, a sheet would be like, it's like a caveman foot, like
another view. I mean,
a size 20 foot.
No, it's a different view. But we got
Innovation that
I made it
excites.
small.
You made it small?
Yeah, he folded up. Yeah,
What's the pattern?
he folded.
You know, and while you're at it, you know, when you're positioning those lateral toes, just, you know, get a little scraper and get some of that fungus out too.
Ew.
Clean between the toes. You know.
Cocoa butter,
They're
like,
gonna give me
Get that
$1,000
cocoa butter in there.
Foot x-rays happen.
As joking, I do say it because as joking as that sounds, you're gonna see some nasty toes.
really are.
Pretty
in the clinic,
much,
guys.
yeah.
People got stuff growing on their feet. It's gross.
I'm gonna teach you guys a
That's
trick.
right, out of their feet.
We'll put
But
some,
those should match.
Bengay.
Bengay.
What you gonna?
No, just go.
What's your trick?
My trick, yeah, you can do some Bengay, you can rub something down there.
What, they gonna burn?
That would
But I
burn.
like having two masks and then having a glove and putting a wipe inside the glove and then kind of like holding it. Because in the morning, what's it called? Gangrene?
Gangrene. What?
Gangrene. And that's basically saying it's a rotten foot. And you know, first thing in the morning, having to smell that, it just ruins your whole day. So always just be prepared, okay? Anytime you see toes in the comments, it usually says what type of feet it is. So just be prepared, okay?
Not in the chakra, you don't know what you finna walk into.
Okay, chakra? Nah, that's
Yeah, chakra is a whole nother level.
That's the
Pack some
wild, wild
essential
west
oils.
up there.
You never know what you're gonna get.
But the Donahue will walk in like,
That's the more tension on you.
put it.
The, the image on the
Pretty
right.
much. I used to be like, all right, out of my way, what you need me to do? All right, move. Get out the way.
And for this image on the left side, what is this?
Right, Mortiz ankle.
And you can tell because you can see how open it is, right?
And also look at how the toes are medially rotated.
To the corner
The
of the
metatarsals, rather. That's not the
15
actual toes.
degrees.
Mm-hmm. Yeah. And a good Mortise always has this open.
Mhm.
And what degree is a Mortise?
15 degrees.
Wait, lateral or medial?
Medium.
Medium.
Perfect. So we can go to the next.
Tunnel.
What is this?
Tunnel view.
PA tunnel view.
Yep.
What's the proper name for this?
That's the intercondylar and boss view.
Mm-hmm.
It could be It could be a plethora of method names. As we'll see, there's a bunch of methods for this as we get into it, but when you can't see the actual positioning, you're just gonna go with tunnel view or intercondylar fossa view. That's the general term for it.
There's multiple.
You have like the Beclair, the Homblad, the Count Coventry, all kinds of stuff.
Like 6 of them.
Is this the right?
Acetagas is for patella.
But like, do we have to know all the names?
Yes, you do. Yes, you
You
do.
already know the answer.
Sedicast,
I'm so sorry. But yes, you
well,
do.
yeah, that's the summaries, and then there's another one, you put it under.
And then what is this called?
Bilateral weight bearing.
Weight
For
bearing.
knees. Yeah, and usually for weight bearings, when they have two of the same anatomy, we put both markers on the side. So we put the left and the right. So when you do weight bearing knees, you do the same thing, left and right. So that's just a great indication to show you that it's a weight bearing procedure.
What does weight bearing mean?
They're standing and putting that
It's
weight.
basically using gravity, seeing how they can hold their weight on the actual foot or knee joint, whatever we're looking at.
Exactly.
What type of pathology do they have?
Bad arthritis.
You see how you can't see none of the joints? You see how this is all mushed up? So that's a good indication that it's a pretty severe arthritis. So this joint's pretty open, but as you can go over here, it's kind of just gone, right? Same thing on the side.
Question?
Yes. Would you call it a weight bearing knee, the same?
No, this is a weight bearing foot,
Feet.
weight bearing feet.
Very, very good. And question, so if they're laying on the table and you're taking a foot x-ray and they're like laying, the knees bent, would that be considered weight bearing?
No.
No, right? Because there's no pressure going into the foot. Same concept for knees too.
Has to be up.
What's this?
Right tip.
Right tip? Yeah.
No.
It's an
What
open.
kind of tip fib is it?
AP.
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 Right, AP tip
Tip
fib.
fib. And does anyone know what this is right here? Go ahead, Jay.
That's the thing that lets you know where they're like laying down or if they're standing. That bead tells us where gravity is.
Yeah, so this bead is just indicating how the placement of they're standing up or lying down. So if they're standing up, the bead would just follow gravity, so it would just be at the bottom of this. But if they're laying on the bed or something, it should be in the center. So that's a great indication that it shows you that they're on the bed. Everybody understand that part? Yeah, fancy
It's the
tech.
kind of markers I used to use. It's too fun.
Just certified tech right there. And then this,
Plantar dorsal axial calcaneus.
Dorsal axial.
Yeah, it's a long name.
Yeah.
Yes.
Calcaneus.
and if you ever forget how to do this image, this projection, it's in the name. So you plantar, dorsal, that means it's entering in the plantar, exiting the dorsal. Axial, what is that?
It's
You
angle.
put an angle on the two, right?
John found with that one, Lab?
40 degrees.
John
That's
found
the
it.
one that-
That's the one with that sharp angle,
Yeah, we
yeah.
saw that.
Yeah.
Cause you have to do
Put
that.
the tape all the way down.
Exactly.
Yeah.
Mom said, it might be so hard for some patients to keep that foot flexed. And every time I would flex, you know, I would like flex my toes, he would just push my toes back. Like, no, relax your toes. It's hard to do that.
I have a question.
Yes, sir.
So for the previous one, the weight bearing, are they standing on the cassette?
Yes.
How much weight can a cassette hold?
That's
Not
a
more
good
than you
question.
realize.
Or
Quite a
do they-
bit.
or
You're
do
not
they
gonna
have
put
like
like a 300-pound patient on it because that would crack it likely, but I would say the max is about 250, what it can bear.
So what would you do if you did have?
So what you can do, that's a great question.
Separate.
What you can do is you have a person sit in a chair and put their feet like this and kind of push down.
Oh, I see.
Yeah. Yeah. That's what we do with kids that weren't cooperating as well.
Put the pressure on.
Mhm.
And just another key factor, anytime you see the ankle joint, no matter what it is, if the ankle joint's in there, it's always flexed, okay?
Mhm.
So always keep that in mind. So it can be a position for the tibia, but if you see the ankle, it has to be flexed, okay?
No floppy feet. You always want a good flexed foot. It's very important. The doctor will send that right back to you.
And I got a quick question. Does anyone know how to properly place the marker? Is it always on the medial or lateral side?
Lateral
side.
Lateral side. And is it always anterior or posterior to the anatomy? Anterior. Think of a lateral chest, it's always anterior. So yeah, you guys got that.
I'm
Okay.
sure every tech in the world does that, right?
Yeah. Advanced option test, very
They don't
example.
use the marker. What do you
They
mean?
just
use
be like,
markers, really.
Yeah,
keep
they
going.
don't use a shield.
No one uses so much of that.
Shoot, these folks don't use no shield.
The one lady came yesterday, she said, I wanna have a shield, and she was like.
Alright, John, I put that in there because I thought maybe it looked like he was smelling the word toes. but He's stuck in it.
Almost. Yeah, you should have flipped it.
Oh, no.
I should have, yeah.
Makes
So
sense.
she actually asked.
So today class, so today class we're gonna be going over all the projections of toe, foot, calcaneus, and ankle. So the next, and then the general procedure guidelines is that always making sure, verifying the patient, the simple stuff, shielding, markers, radiation protection, patient instruction, and collimation and size. You know how we like the collimation and how Mr. Donahue likes it, right? Not open and off the cassette like on top, okay?
Wait, go back. On the patient prep, what is gonna be vital in patient prep for lower extremities? What are we referring to there?
Remove your pants and your shoes and socks.
Remove the pants or roll them up, shoes and socks, because
Jewelry.
a lot of trash techs, so I'm gonna say it plainly, will just leave the pants in the way. You're gonna have artifacts all over that image. It looks sloppy. Some people leave the socks on. You can see the socks. It looks sloppy. Remove all that, get that out of your way. It's gonna increase the quality of your image. It's vital for these lower extremities. Don't be one of those types of people. Don't be one of those types of techs. Get it all out of the way.
Everybody good on this?
Nate, just a question on clothing. I noticed they're very specific. If it's jeans, I've seen some even try to do it, and then when the images don't look good, then they say, hey, remove the jeans. A lot of people, it's weird, even I guess guys now, they're wearing kind of like leggings and tight fitting sometimes kind of stuff. Is that okay? Like
No.
that? No. So still okay.
Still. Just like even, underwear is going to show up, which is why on KUBs, even though a lot of people don't ask patients to take the underwear off, ideally and optimally we should get them to remove the underwear because the waistbands and things will show up, logos, all kinds of stuff still shows up. Always optimally, any kind of clothing you can get out of the way is going to be the best choice, period. Otherwise, just lazy tech if you ask me, they leave all that on there. Sloppy.
Oh, MeUndies, nice.
Shirts are dependable. It depends what it
I
has.
still would have them remove shirts personally.
You do too?
Different fabrics, and of course, different digital technology is going to pick up on it better as well. The better quality machines you're using, the more it's going to show up. Yeah.
So on to the next.
Yeah, if you ever want to know what you look like wearing heels, by the way, put that in there for you.
That looks painful. I give you props, guys.
My wife wears heels all the time, so.
So yeah, what Mr. Donahue was talking about, always remove the shoes, the socks, and heavy fabrics. This happens to me sometimes on the tech. They're like, oh no, it's fine, we have to take an image, and then we have to reshoot the image, and that's against what rule again, guys? Alara, right? So that's just bad for the patient, and it just looks bad on us. So we're going to the next. So general patient position. Ambulatory patients can be seated or supine on the X-ray table. Effective extremity rests on the IR placed on the tabletop. So yeah, like Mr. Donahue was saying, for weight-bearing knees, weight-bearing feet, you can either do them sitting and having pressure on the foot, or they can have it being standing. Correct? Non-ambulatory patients alter the position to maximize patient comfort. Transfer from stretcher to table is not necessary. So
Just to go back a little bit here, one thing that's really great about these lower extremities, just like with the uppers, assess your patient's situation. Ideally we'd like them on the table, but if they can't get to the table, think outside the box. I can still do a 3-view foot sitting in a chair. I can put the cassette on the floor and position my patient and put the tube over the cassette, right? We've got flexibility. We always want to take patient care into consideration and do what's most comfortable for the patient. Why? They're gonna cooperate better if I am adhering to their comfort levels. Because these people are in pain, a lot of them have really bad fractures, whatever going on. The more comfortable I can make them, the more optimized my image is going to turn out. They're not combating me against it.
and the quicker the exam goes too.
Yeah. Expediation, expedite.
Because I had a patient, she was an 80-year-old woman, and we were doing feet x-rays, but she was in the chair and she couldn't move at all. So instead of moving her to the table, how we usually do it, we just shot it from her seat, and we raised her foot onto the table and shot it from shooting it just on the table. So moving it very flexible, kind of like that. Does that make sense? No?
Yes.
Makes sense.
Makes
In
sense?
the outpatient, they do chairs, like, just have their foot on the chair.
Yeah, put it on the chair, you can do it like that too.
It's always better you can think outside the box.
Did you hear it?
This isn't a sharp curve.
What?
They said they use the sharp containers to balance up the foot.
Hey, you gotta use what you gotta use. Hey guys, no joke, no joke. One of my proudest moments as a tech in the trauma room was I had to do a foot like this one time. I'll give y'all a visual here. So I had a patient come in on a stretcher. Don't make fun of my drawings, they're not very good. But imagine here's your patient, like this. And let's see. Trying to
It's
think.
bad.
He's sad. Look at his eyes though. Here's an ugly foot.
It's very dislocated.
So he's laying on his stomach?
So that's how my patient arrived.
Oh.
Face down with the foot up in the air and the leg bent.
Face down.
Um,
Yeah.
Hang on.
Absolutely not.
Hang on. I'm drawing this correctly.
It doesn't look good.
Reggie's like, can you say body
Their parts say that.
It was more so like, there's the knee and the foot was like this.
Oh.
It was messed up. It was elevated like that. So the doctor asked me for a 3-view foot with a patient like this, and I couldn't move the patient. So you as a tech, you walk in the trauma room and you're asked to do a 3-view foot. How would you get a 3-view foot?
He's laying on his stomach? Was he laying?
He's laying on his stomach.
Okay.
Yeah, I'm sorry, my drawing's terrible.
That's good, okay.
Yeah.
Somebody's gonna have to hold it.
Yeah, somebody's gonna have to hold the cassette.
Sure.
Like stop a whole bunch
He's
of
saying
stuff.
I'm going to lunch. Ouch.
Yeah.
How would you get a 3-view foot?
You have someone hold the cassette?
Yeah, that's the
Put a
only thing
shield
I
on?
could think of.
And keep in mind, first use an AP axial foot.
Mm-hmm.
Oh.
So
You'd have to come cut it.
I called the nurse over, said, here, put this on, hold this. I'll put the cassette behind the foot, like so. Bend my tube at a very sharp angle. Draw. And shoot like that
Mm-hmm.
with the portal. And put a 10-degree angle on it.
Mm-hmm.
That's how I got my AP axial. Let's you flip for the medial. How would I get the lateral?
Put it on the side.
Put it on the side, cross table. There's your 3-view foot. That's called thinking outside the box. A lot of people walk into that and say, well, I can't do that. I can't do that. You just have to wait till they're in better condition. We can always get an image. I don't care how their condition is. You can always think outside the box and get a good image. You just have to think critically.
We use the trash can.
You use whatever you have available.
Mhm.
Make your nurses work. Make the doctors work. Here, put this on. Put this lead on. Hold this for me. And you can recruit people to help you out, but you can get creative and you can always get a good image if you just think beyond the book. What I want y'all to start learning how to do is to think beyond what the book says. The book's there as a guide, but it's simply a guide. You can always get creative and come up with your own views, essentially. That was a Donahue view there. I termed that the Donahue method, or a backwards foot. That really is a terrible drawing. I'm so sorry.
We get the point.
Go ahead, Jalen.
So yeah, try to create something and put your name in the book one day, okay?
Oh, just wait. I got a great story for y'all. When am I gonna tell it?
The pencil?
The sunrise buttocks.
Buttocks?
Oh.
Sunrise buttocks view.
Yeah, okay.
We'll save that one for later.
Yes, please.
That one's gonna use.
John's wants that one now.
So this is really big on here. Test question right here. So all projections dealing with what we're going over is gonna be at 40 degrees, okay? 40 at SID. Everybody got that? On to the next. So the ID markers, right or left markers, must be included on the IR. Avoid using digital annotations to place side markers on images. That's a really big one. Always put physical markers instead of digital. It's really important. And then if there was ever like a legal issues, they prefer using actual physical markers because digital can be placed like any. What would you say for that?
What did I say for that?
Yeah, the digital markers.
You said it correctly. So if it was ever a legal matter and they need to use your images in a legal case, if it's digital markers, it's not considered a legal document. Only those with physical markers could be considered an actual legal binding document that can be used in court and law.
So it's very important.
Very important, in the cases of, abuse cases with children, when they're having to investigate, try to remove custody from parents. They can't just use something with a bunch of random digital markers that wouldn't fly in courts. You gotta have that actual physical marker, which is why at TCH they would always make us repeat images period. It could be the most beautiful image you ever took, but you had to redo it if your marker wasn't on there. If it ever came back on you, that'd be a lawsuit against you and the facility. So, it was a pain because I had to repeat a lot of pretty images because I might have dropped my marker, it fell off, but you gotta have it on there.
But this is excluding, for example, like weight bearing. There's a little button that says weight bearing. You can put that as a digital annotation.
No, you cannot.
You can't.
That needs to be physical as well.
We have physicals for that. I
You
never
do.
seen that. Okay.
It is Heidel. They're there though.
They're there though. Okay.
We have markers for everything.
For everything. I've never seen one of them.
Yeah, you never ever use a needle marker, period. Even though we see it per the ART, it's always physical markers for everything. Period.
Period. Okay, and radiation protection. So we always want to have a tight, close collimation whenever doing it. And go down shading is very important because most of the time when you can always apply it, it won't ever be in the way of an image. Okay, so always just take that extra 2 minutes to apply the extra protection. And then whenever you put it on, just always specify to the patient that this is for your protection. Let's put this on. Just don't put it on them. It gets them really anxious. Like you guys be weirded out. Someone was like, "Here, throw it on," right? So always, whenever in the procedure, always explain to the patient what we're gonna do. Okay? Makes things a lot more smoother. And get in and get out.
So if you're wondering, I always put GIFs for a reason. The reason I put that GIF is because that's my face whenever someone's using AEC, and I go back and correct it with manual technique. That's how I feel right there.
You go back in time.
I hate AEC.
AEC.
It's lazy and it's suboptimal images. Yeah, that's my stressed out face. It's sloppy text.
Do we know what AEC is?
Control.
Automatic exposure control.
Alright, good. And there's really no breathing instructions with this one because we're just doing hands and stuff. So, not hands, but feet. And we're looking only for the bones within.
So guys, it should be common sense, but we don't really need to tell them to hold their breath for a foot x-ray. I don't think anyone's breathing through their toes, unless you got some secret superpower we don't know about, like some mutation. So, great test question. You'd be surprised how this fools people. What is the breathing technique for an apiaxial foot?
Suspend on inspiration.
You say that, but you're surprised how people will default to selecting that because that's what you normally think when you see something about breathing technique. Oh, it's either inspiration or expiration. But that's why I'm trying to get y'all used to reading those questions carefully. Wait a minute, it's a foot. There is no breathing. So none apply. No breathing at all. Just carefully read those questions.
And just tell the patient to hold still because we don't want any movement. And this is a Mr. Fong question. What kind of KVP will we be using? Like high or low?
Low.
Low? Because we're seeing bone, correct? Okay, now we'll go to the procedures, the center ray, the angulation of the zany.
That one's for you too, Jay.
Toes.
That's how you feel when you talk about toes.
Yeah, anytime I see a toe sheet, that's how I'm feeling. I'm ready to go.
That's his exact reaction right there.
Exactly.
You want the uglies?
The uglier the better, you know what I'm saying? It's bragging. You know, it makes my day.
Gets vascular.
So the central projections for toes, we have anterior posterior, AP or AP axial, APOB. For the laterals, we have medial lateral and lateral medial, and then we also have the sesamoid. The sesamoids, I've rarely seen these, but the top three right here, you see these very often.
Yeah, I've never seen a sesamoid
Sesamoid,
on an X-ray.
yeah.
They do exist.
They do exist. Yeah.
They do. Can anyone tell us why there's like two options on the lateral? Those of you who've been in lab should know that.
In, out.
What the cause is.
Because of what?
You alright?
Isn't like
Pressures?
oblique, like usually it's, you turn your foot medial, like when you do a lateral foot, you're gonna turn your foot laterally.
Depends on the toe. Depends on the toe, guys.
Oh, we talking about
Depends on the digits.
Depends on what.
Oh, yeah, what digit you're doing.
What
Okay,
toe is the star of your show? That rhymes for you. What toe is the star of your show?
So when whenever the key is to have minimal OID to reduce magnification, correct? So for example, if it's the first toe, which one would you do? Medial lateral or lateral medial? Lateral, okay. And if it's the fifth,
Half of the beam. Half of the beam. So big toe would be what projection wise?
Lateral medial.
Lateral medial.
Lateral medial.
It's entering the lateral aspect, exiting the medial aspect.
Closer to the
Yeah. That's following the path of the beam, guys. That's what medial lateral versus lateral medial means.
everybody understand that one? It's from anatomical position, okay?
So if you go to fifth digit, it'll be
Medial
medial lateral.
lateral.
Oh,
Yeah.
I like that.
Mhm, exactly.
Boy, that pinky toe, let me tell you, that pinky toe is hard to x-ray. Super tight collimation.
Everybody good on this slide? On to the next. So yeah, so collimation is always key. You always want to use the same collimation size. And the radiation field is 1 inch or 2.5 centimeters. We really don't use centimeters, but focus on the inches. On all sides of the toes, including 1 inch proximal to the NTP joint. So just basically saying just have really good collimation on that toe, okay? So when you're doing a toe, don't get the tuberosity of the calcaneus, basically.
Right, there's a difference between a foot and toe
Toe,
x-ray.
exactly.
Now you will notice, I'm sure some of y'all have noticed in clinic on the protocol, much like if you're doing a finger x-ray, if you're doing toes, they usually include AP axial foot with it, and then the other 2 toe x-rays. That's usually the protocol. But in some facilities you have the separate AP toes, medial, lateral, which is what we're gonna review here.
Yeah, and that's one thing. When I was a student, I always got confused because the teachers would say something else, but the clinicals would say something different. So whenever you go to a new job or new facility, always look for the protocol book and see how they do it. Because there might be new procedures that you never seen in class before, but they do it over there regularly. So just always, first thing you go in there, it was a protocol book, and just read through it and see what they have different from what you guys learned or been taught. Everybody's good on this?
In MLK, they do the scapular Y and AP.
Not PA, right? Yeah, so that could be it, yeah. That's
There's always little
definitely-
variances
Exactly.
per facilities.
So the first thing that we're doing is the AP and AP axial toes. And basically the axial, anytime you see axial, what does that mean?
There's
Angle.
Angle to what? The foot, the anatomy, the tube,
the two.
the tube, right? Correct. And so we can do this seated or supine. What is seated? What Mr. Donahue was doing, right? And supine is what? Laying down? Where? Stomach or back first? Back first, right? Okay, awesome. And so for the supine, you can have the knee flex just like this, right? We see if they're laying supine on the bed, you can bend the knee and then place it right on the cassette. Is this considered weight bearing?
No,
Why not?
Well,
because the weight is on yours,
There's no
where you're
weight.
sitting.
Yeah, there's no applied weight on the foot. And then the part of the position, knee flex with the sole and the foot, and then toe center to the IR. And just basically saying just the toes are centered on the middle of the IR of the cassette.
So you're gonna see multiple methods here, guys. We have one where you see the the toes are flat on the board with a perpendicular central ray. You have a method where they're elevating the foot to simulate axial, but we also have a method we're gonna talk about where we actually angle the tube, as you learn in lab, 10 degrees. Now, when it comes to the choices here, you have the option of AP or AP axial. Both are considered acceptable, but the optimal way to always do AP toes is with the angulation. Why? You can read that little note down there on the bottom, Jalen.
AP axial recommended to open the joint spaces and reduce foreshadowing.
For shortening.
Foreshortening.
It's always going to be the optimized view of AP axial. You have the choice of both, but always opt for a better image to the axial view.
And then what does the angulation on the tube do to the bone? Does it elongate it or foreshorten it?
I think
It elongates it, correct. So whenever you angle the tube, it always elongates the anatomy. But let's say that the central ray is perpendicular, but for example in this image, the central ray is perpendicular, correct? But the anatomy is angled. So what does that do to the bone?
also
Elongates it.
Isn't that foreshortened?
No, it's still elongating.
It's still
This
elongating?
way, yeah.
Because
You're thinking backwards,
I
but
thought Mr. Phone was like,
no, this is still elongated
Yeah,
because
okay.
we're basically, you can either add an angle to the tube or angle the part. Both are going to be the same thing.
I think that was it.
So when you angle the tube, it's elongated? Okay.
The way we're angling the foot here would be elongated. If the foot was angled the other way, like with the toes down, that'd be foreshortening it.
So is that the same sort of principle as OID? Because you're taking a certain spot and magnifying it from the
You are.
rest?
You are. But I don't recommend this method with the wedge. I recommend just angling your tube. That's the easier way to do it.
I've never seen this before, so.
No one has those sponges anyway.
They do. It's hot.
Oh, they're hiding
They
them?
hide it too.
They sell them on eBay?
Yeah. They have it in Flora, every They're all like with dust and everything on them.
IR's got a lot of sponges. They throw them out after every like case that they use.
Do they?
Talking about the sponge for the head. That's just like
Oh,
a
yeah,
cushioning
that's a
sponge.
cushion.
That's just a.
So they're not radiolucent?
They're the radiolucent, but that's not for like angulation. Because there's some sponges for the hand, for the oblique, they have it specifically for that. But this sponge for the IR is just for cushioning, so that's why they throw it away. Yeah. On to the next. So the censure ray is perpendicular. This is an AP foot right here.
And,
the
and before you go on, I do apologize, guys. I made a misstatement. This is different from Bontrager. This is the Merrill's method. That's a 15-degree angle. I need to make sure y'all doing it that way in lab. We're all doing 10.
We got
15.
So
You are doing
He went
15.
by,
Yeah.
Good,
the
good.
barrels.
Go ahead.
15?
I thought I read somewhere 10 to
15, 10, 5.
You'll see the range sometimes, but
Tons.
ideally, per Merrill's, and that is your gold star text to go by, that's a 15-degree angle
What
for
is 10?
optimized angulation.
Taught us wrong.
I didn't teach Bond.
Bontrager.
The
5,
ankle you don't stand up
I've been
for.
trying to get Merrill's for a while. I finally got my way on it.
15,
I mean, you
10.
don't angle for it.
There's 40 for the calcaneus.
Yeah.
So
Yes.
yeah, so key. So whenever you angle the angulation of the tube, it's 15 degrees posterior. So posterior means it's facing towards the what part of the talus? Calcaneus part, the back of the heel. So as you can see, the angulation is going towards posterior, which is going towards the calcaneus. As you can see right here. And then the CR is centered on the third MTP joint, metatarsophalangeal joint. Okay, when you're doing this. So I got some bones right here on the table for y'all. Can anyone just point at the third MTP so you guys can physically remember?
Third MTP.
There you go. Alright. You got a good look on that?
And you can palpate that on the foot as well. You can feel that joint. No, y'all don't really want to touch people's feet, but you can feel it.
You can touch their feet, I don't think they care.
Patients, they'll let you.
Oh, it feels ticklish.
Wait, so there's no mistake in this?
No, this is correct. 15 degree is the optimized angulation, that foot x-ray. You'll see a range of 10 to 15, often in text. 15 is always considered the best way.
No, so
There is for
It
the
is
foot.
10 degrees.
Foot is
We're gonna
10.
get to the foot.
So this is a key big factor. So the test question says, what is the main reason why we do add angulation to the foot? And that the reason why is to open up those joints, okay? Exactly. I done it one time where I forgot to add angulation to an AP foot. You can really tell how it just closes up the joints. So when you do an angulation, it opens it up and it makes it easier to read for the radiologists.
Lazy text, superstar text. If you want your stuff to look good, always add that angle. I said add the ankle. Add the angle. Don't include an ankle on your toe x-rays. It's superstar.
On to the next. So yeah, so for this one, the things that you should be able to see is all 14 phalangeals. So we have 2 in the toe and then 3 in the other phalanges. Correct?
14 total.
14 toes in total. So that's gonna be a number. How many phalanges should we see in the AP toe? 14, correct?
Can y'all see the difference of the non-angle versus the angle on the phalanges?
Yes.
See how they're closed off on the left versus the right?
You can really see it in the IP joint. You see how the IP joints really like touching each other, and it's separating right here. This is what the doctors want to see, right? And when you put your marker on there, they gonna know exactly who was a lazy tech and who was a optimal superstar tech. Okay?
They notice. They do notice that.
Yes, sir.
So is this the evaluation criteria?
This is structure shown. We're almost to evaluation criteria on the next slide. Also, I don't think this was mentioned on the positioning, guys. And this is a recent change as well. We used to isolate the toes on the APs. Now we always do a full view of all 5 on the APs. We don't column it down to the hurting toe. It's always basically like a comparison view of all 5 at the same time.
Like the hand, when it's just like a single, they do the whole hand, then
Yeah.
they do the single.
Mhm.
Okay.
Yeah.
Everybody good on this?
Mhm.
Alright, on to the next. So evaluation criteria. So evidence of collimation, 1 inch from the center ray. So we have 1 inch going everywhere, like a square. Another thing, side marker visible and clear of anatomy of interest. So this is optimal, but not optimal because what's the main reason? We're using a digital marker. Always use physical markers and place it on the lateral side of the foot, correct? And then another evaluation criteria, you want to get the entire toes, so all the way 1 to 5, very important. So let's say you have an image right, everything looks good, but you guys are clipping this right here, this little joint right here. Would we have to redo it again, or would we just extend it?
Yeah, redo it.
Redo it, right? You want to get every toes in there, every toes in there basically. And you want to get the distal ends of the metatarsals as well. So distal ends of metatarsal, right? Distal end, distal end, distal end. That's good. And then you also don't want rotation of the phalanges. And the best way to tell if you have rotation of the phalanges, you see the little spaces right here, the metatarsal spaces in between. And those are pretty basically even with each other. That's how you know you have not much rotation. But if the rotation on the phalanges, you will see these overlap sometimes. So that's a good indication. Yes, sir?
Do you mean, so rotation of phalanges being like one is turned?
Yeah,
Or as opposed to like an obliquity? 'Cause-
If it's turned, it is oblique.
It's oblique,
Okay.
yeah. If it's turned, it's oblique. Obliquity means just turning of the anatomy, basically. Yeah. So you can see how this is basically much even. Not a lot of them are overlapping, right? So that's a good AP. If they were touching or one was on top of each other, that's how you know you have obliquity within the X-ray. And yeah, so with the angulation of the tube, you should always have the open IP and the MTP joints very open with the axial. And yeah, so that's what makes it a good AP or AP axial toe image. Anybody have further?
You said the bottom one is the more preferred than the top one?
Yes, because the top is just perpendicular, the bottom has the actual angulation, which opens up all those joint spaces.
You can hardly see any of the dips
So if
open.
you look at these,
Yeah.
how closed off they are, versus here, they're very open. You probably see on the TV screen a little bit more clear.
Yeah, look
You
at
can
the
see
IP
it
joint
clear
on top.
on the TV,
And
but
then
it's
look at the
there.
one at the bottom. Can you see it?
Go point to it, Nancy, so you can know.
The dips are all open on the bottom. So are those soft tissue lines?
Yes,
Okay.
that's where we'll stop today, Jalen. We're after 10.
Okay.
2 hours goes fast.
Yeah, that went about fast.
All right, guys.